Hi, everybody. Good afternoon, and thank you for being here. I know everyone has probably better things to do on a wonderful, beautiful summer afternoon, so I appreciate you spending some time with me. Today's talk is going to be about the shoulder, and specifically we're going to talk a little bit today about rotator cuff injuries and also shoulder arthritis. And we're going to talk about kind of some of the latest and greatest things that we're doing here at the OrthoTeam clinic at Stoughton Health, and different options that patients have for shoulder problems. So for those of you who don't know me, I am a board-certified orthopedic surgeon, also board-certified in sports medicine. I've been in practice for over 20 years, and I'm currently the head of the shoulder center at the OrthoTeam clinic, in addition to my other responsibilities. The shoulder center is something that we launched back in 2022, so over the past 4 years. And that shoulder center is aimed at taking care of comprehensive shoulder care, from everything possible to fractures, arthritis, rotator cuff tears, unstable shoulders from dislocations, what have you. So kind of soup to nuts, we take care of all shoulder problems. So it's one place to go for everything. At the OrthoTeam clinic, we have two locations, one at Stoughton Hospital at our new outpatient center, as well as our West Madison office in Research Park. We have telemedicine and in-person visits available. So what are we going to talk about today? So we're going to talk in general just about the shoulder, how it works and what kind of problems we can run into. We'll talk a little bit more then about rotator cuff issues that someone might have and how to diagnose that, and then what our treatment options are. After that, we'll talk about shoulder replacement, specifically, who needs one and what symptoms might you have and how do we diagnose that. Then we'll talk about the Mako robotic shoulder replacement. That's something that's new for us here at Stoughton Health, and we've been a pioneer in Wisconsin for that. And then we'll conclude with just what a care journey would look like if you go through treatment. All right, so let's talk a little bit about anatomy and what kinds of things can affect the shoulder joint in general. I like to divide things into two main categories. One is acute pain that someone might have, and versus chronic pain of the shoulder, meaning it's been there for a long time. And you can see the differences are sudden onset versus gradual onset. Sudden onset may happen from one specific injury or a fall, and can involve swelling and bruising. And for that, usually an immediate evaluation is recommended. Obviously, on the other end of the spectrum is a chronic pain issue, where this tends to worsen without any specific injury, and patients will have maybe a deep ache or stiffness or weakness that they notice develops over time. And for many, it's there for quite some time, months or years before they seek treatment. The four main symptom categories that I talk about, when we talk about shoulder issues, one is pain in the shoulder. So we talked about aching pain, burning pain, sharp pain, and that can happen at rest with movement, at night or while awake. Stiffness is another problem that patients encounter as well. Difficulty reaching overhead or behind the back or across the body. There's weakness. So some patients will have issues where they cannot lift their arm over their head, and they're not able to carry objects and perform tasks that they were once able to do with ease. And then unstable joint or instability, that's where you have a sensation that something is moving potentially out of place, and that pain then can limit what you're able to do. Let's talk a little bit about what does a shoulder look like and what's the anatomy that we'll be talking about. So we know the shoulder is a ball and socket joint, and it happens to be one of the most mobile joints in your body, and it can move in every direction. We know it can move forward and back, internal, external rotation, and move from side to side. there's three bones that really make up the shoulder joint that we look at. One is the ball and socket joint, which is made of the humerus, which is the top end of the bone, which it makes up the ball. There's the socket, which is made of the scapula bone, which is actually part of your shoulder blade. And last is the clavicle, which is your collarbone. So at the top of your shoulder, you'll have that. So those three bones together kind of make up the shoulder girdle. And then there's the rotator cuff. And you can see here on the picture on the right, you can see the kind of red areas that become white ribbons, and that represents the rotator cuff. And so the rotator cuff is a series of muscles that start on your shoulder blade, as we can see here, and then turn into these thick, flat ribbons that attach on the ball, and that's the tendons that attach your rotator cuff. And those go wrap all the way around your shoulder like a cuff, and hence the name rotator cuff. When we talk about causes of shoulder problems, we first talked about what are symptoms patients may have, but then we'll talk about what are actual problems and what do they represent. So rotator cuff disease is something that's very common as we get to middle age and beyond, and that's when that rotator cuff, especially the tendons right at where they attach to the humerus bone, can tear, and that tearing can cause pain and weakness and limited motion. And it's one of the most common things that I treat. Next is arthritis of the shoulder. Well, the nice way a shoulder moves and that ball and socket can move really nice is because you have a nice smooth cartilage layer that allows for a nice gliding motion. But over time, that nice smooth cartilage layer wears away, and then it's like feels like two pieces of sandpaper trying to move past each other. And that'll cause this deep aching pain and stiffness that tends to worsen over activities or over a long period of time without using the shoulder. Next are fractures of the shoulder. So some people call them breaks or fractures, but you can have a fracture of the humerus bone, the clavicle, the collarbone, or the scapula, which, remember, the socket is part of that bone. Typically can happen from a fall or some type of trauma. Some require surgery, but luckily many of them that we see don't require surgery at all. And the last one is shoulder dislocation. So that's when the ball and socket joint actually moves and slips out of place, and that can lead to a repetitive instability of the shoulder, and sometimes those can require surgical treatment. So how do we diagnose these problems? I think one of the most important things is to talk to the patient. I know that if I spend a good amount of time just talking to the patient and reviewing their history and how they got to this point, I can ascertain most likely what the cause is, and then combine that with a physical exam, being able to see how well the shoulder moves, how strong the muscles of the shoulder are, and other maneuvers can help diagnose what structures may be problematic. In addition to that, other modalities that we use in the office setting, we use X-ray, as well as using CT scans and MRIs, advanced imaging studies, to help look at things such as fractures, which are better on a CT scan, and MRI will take a look better at soft tissue, such as your rotator cuff, cartilage, labrum, etc. Ultrasound is also another wonderful technology that can be used as a non-invasive way to also diagnose various ailments. Let's talk a little bit about rotator cuff tears. We know that in general, when someone does tear their rotator cuff, that sometimes they can require surgery to help relieve the pain and then return to the activities that they love. But it's important to know that not all rotator cuff tears require repair, and it's important to know which ones may require repair and which ones don't. We know it's a very common problem in the U.S. Over 2 million people every year will see a doctor for some type of rotator cuff ailment. And believe it or not, once we turn age 60, 40% of us will have some type of tear of the rotator cuff. So obviously, with numbers being that high of people who have potentially rotator cuff tears, obviously we do not do surgery on everybody. But it's really based on the symptoms and the function that the patient have, not just an MRI that shows us that someone might have a rotator cuff tear. So what is a rotator cuff tear? Well, if you take a look at this picture on the right here, you'll see an area here where the muscle and tendon attached to the bone, and where that can become detached is where we have a tear of the rotator cuff. That rotator cuff has a pretty thick attachment. It's about 15 millimeters in thickness, which translates to about 5/8 of an inch. And so tears we divide into partial tears, where it's only torn part of the way through, versus a full thickness tear, where it's completely torn through and through. For partial tears, initially the treatment is going to be non-surgical in nature, and many patients do respond to that. Many times it'll be things such as physical therapy, injections, and obviously the tincture of time. Full thickness tendon tears are when the tendon completely detaches, and sometimes we do recommend surgical treatment, but not all. So it really depends on the patient's function and status. So like I mentioned before, not every rotator cuff tear requires surgery. The factors we look at are obviously the age and activity level of a person. If they're low demand, then it's something we may not recommend surgery for. The size of the tear we talked about in terms of partial thickness or full thickness, and how many tendons are involved. The acuity of a tear, something that's acute traumatic tear may benefit from surgery, while something that's been there for a long time may not benefit from surgical treatment. How much the muscle is atrophied and how much the tendon is retracted, that is sometimes a function of time. So many times if someone has a rotator cuff tear that has been there for many years, it may not be able to be repaired, and they may actually be functioning quite well and may not require any surgical treatment. The overall health of an individual also plays into that. Obviously, things like smoking and diabetes can affect the ability to heal after surgery, and so that can change our recommendations on who needs surgery. And then obviously how people respond to conservative treatment. If the simple things, the non-invasive things can help them and they do well, then obviously surgery is not something we want to move forward on. Also, we have to think about what other structures in the shoulder can be causing pain besides the rotator cuff. Many times patients will have an injury or tendinitis of the biceps tendon. They can also have arthritis of the small joint on the top of the shoulder where the collarbone meets the roof of the shoulder. So those things need to also be addressed and taken care of because they may be able to solve someone's pain without necessarily needing any surgery. But the goal overall is to restore function and normal daily activity. So most people who I see who tear their rotator cuff, they're not looking to throw a 90-mile-per-hour fastball or do anything like that. They want to be able to do simple things like place something in a high cabinet, reach behind their back, play golf, maybe play with their grandchildren, things that are all reasonable and they can potentially benefit from further treatment that can help them restore that function. In terms of non-surgical treatment, meaning things that we wouldn't treat with surgery, physical therapy is a mainstay. The physical therapists we work at Stoughton Health and other organizations do a great job in helping people get back to normal function many times without requiring surgery. And so that's a very important early treatment for patients. Medications such as anti-inflammatory medication can be helpful. Injections can also be helpful as well. Corticosteroid injections, or what people call like a steroid injection, can be helpful to kind of help quiet down the pain to then allow physical therapy. The cortisone injection is not intended to last forever, because that's everyone's first question: how long will it last? The goal is that if it can temporarily decrease the pain and inflammation to allow that next step of therapy and rehabilitation, then once the injection wears off, it may be fine and the person may be feeling well. Obviously, activity modification and rest. Common saying, "Doctor, it hurts when I do this." And we say, well, don't do that. Makes sense to some extent. And we want to make sure that while someone is getting better, that we do modify their activities so that way we're not picking at that same scab again and again and not letting things heal. But again, many of these times, partial thickness tears or low demand patients, those are going to be the ones that we're really going to start up front with conservative treatment. And even patients with full thickness tears, many times we can recommend conservative treatment to start off as well. In terms of how do we fix these, usually it's an arthroscopic repair, meaning the surgery is done with small incisions and a camera is placed in the shoulder, and small instruments are used in the old way of making a large incision on the shoulder and directly looking at the rotator cuff tear to fix it. That's something that really is not done much anymore. And what happens is the tendon, we reattach it back down to the bone using stitches and anchors, and I'll show you a short video on how that works. Usually this is done as a same-day outpatient procedure, and usually surgery could take an hour, hour and a half, and patients usually are at the hospital for a few hours overall. Like we talked about for arthroscopic repair, again, small incisions, 3 or 4 small incisions to allow us to look inside the joint and make a repair, and then the tendons are reattached. And like I said, usually 60 to 90 minutes. The nice thing is we perform these on an outpatient basis. One of the reasons why it's much easier to do this now than it was 20 years ago when I started was the anesthesia part is really improved. It usually is general anesthesia for this, but the nerve block that a patient gets prior to surgery, the newest nerve blocks that are performed last up to 48 hours, which is really great because the first 48 hours is the most crucial in terms of pain. So we find that many people, by the time the block wears off, they're quite comfortable, and some are actually able to get by with just some Tylenol and ice. So here's a quick video I'm going to show you, and that's going to show you how an arthroscopic rotator cuff repair works. These are small cannulas or tubes that we use that we kind of are able to look inside the shoulder and pass instruments, and then we're able to place small anchors in the bone, and that allows us to sew this tendon and repair it back down to bone. There are other advanced procedures that we do now, and the main name of the game is having our rotator cuff heal. So my job as a surgeon is to place it back where it needs to be, but then the human body is meant to actually heal that back down. And so we want to make sure we have the best biologic environment for that. Just like if you were planting a garden, you have to make sure you have all the right things in place for that garden to grow. That means good soil, good plants, watering it, fertilizer, etc. The same goes true for a rotator cuff repair. In times where we feel that maybe the tissue quality or bone quality isn't good, we are able to use augmentation to help that repair, similar to using Miracle-Gro. Sometimes that involves using a biologic or synthetic patch that can be that extra strength that the rotator cuff needs to repair. Other option that we have, we'll talk about, is in-space balloon spacer. So sometimes in people who have rotator cuff tears that can't be repaired, we can place this device that kind of holds the ball and socket joint in place and still allow the shoulder to function without having the rotator cuff repaired. And then in other cases where rotator cuff tears can't be replaced, sometimes we perform tendon transfers, which means we take tendons that are good and working in somewhere that we don't need their function and move them to a place that they do need. So it's a little bit of robbing Peter to pay Paul, but we do it in a way that doesn't sacrifice the function of your shoulder. So here's kind of a picture of an in-balloon spacer. So here we see that here's a rotator cuff that was repaired, but many times it's in a rotator cuff that can't be repaired. There's basically this device that's a balloon that we inflate with saline, and that holds the ball down in the socket. And that can be something that can help restore function for people who have rotator cuff repairs that can't be replaced. Another is a tendon transfer. And that, like I show here in the picture, we're able to reroute a tendon from the back of the shoulder and then re-anchor that back down and act as a substitute for the rotator cuff. And let's see if this video works today. No, for some reason the videos are not working today. Must be not clicking on the right spot. In terms of recovery and return to activity, we know for rotator cuff repair standard, patients are usually in a sling for a period of 4 to 6 weeks. During that time, they're icing, doing some light activities. We allow patients to drive usually at 2 weeks, as long as they're not taking any pain medication. At 6 weeks, we begin more advanced range of motion. Actually, the passive range of motion that we talk about is really at the in the 0 to 6 week mark, and this active physical therapy is really during the 6 to 12 weeks. So active meaning you're moving your shoulder by yourself, and then at 3 months, that's when we really begin the strengthening part. So what does a day look like in someone who's having a rotator cuff repair? They arrive in the morning and it's a pre-op phase where they come in, they get checked in, get their IV placed, review the plan with the surgery and anesthesia team. Nerve block is obtained, patient is positioned for the surgery. The surgery part lasts 60 minutes to 90 minutes. Then it's a trip back to the recovery room after that. And then usually within an hour from that, going back to day surgery and then ready to go home. And for the vast majority of patients, because that nerve block is in place, they're going home and not really having any pain. Let's move a little bit forward now to shoulder replacement. And obviously the diagnosis that requires shoulder replacement is arthritis of the shoulder, meaning the loss of cartilage in the ball and socket joint. Replacement is obviously an option that we're going to recommend when all other non-surgical options are exhausted. We know that shoulder replacements are something that are quite common in the US, and I think we're finding that there's more people that are needing shoulder replacement because they now understand that it is a problem that can be addressed. And as a matter of fact, it's the third most common joint replaced in the United States. Most patients are very familiar with hip and knee replacement. Less patients are familiar with the idea of a shoulder replacement. But it has been around for a long time, and it has been proven to be really effective in improving patients, relieving their pain and improving their function, just like a hip or knee replacement would. And there's many studies that show that patients do very well and are very happy with a shoulder replacement. So what is a shoulder replacement? What basically happens is the cartilage on the ball and socket of a shoulder joint is damaged, and then that gets replaced with a new ball and a new socket. Traditionally, the ball is made out of metal with a prosthesis that goes into the bone here, and the socket is usually made out of a plastic material. It is usually the best option for someone who has end-stage arthritis, but it does require that the patient have a normal, intact, functioning rotator cuff for that to work well. And it does a good job of restoring natural mechanics and function of the shoulder, and it can be a very effective long-term solution for relief of pain. So it just shows a little closer picture of that. And as we see in this picture here, this is a short stem implant. So traditionally, when we used to do this procedure over 20 years ago, this prosthesis would go clear down here. And so it was a big, large prosthesis with a ball on top. Then we've moved to a shorter stem, which we see here. And now for many patients, when we're doing this type of anatomic shoulder replacement, it's a stemless prosthesis, so it really only just goes down to here. So it's less violation of that bone canal and tends to be less invasive for the patient. And this just talks a little bit about that. Another option that we have in 2026 is hemiarthroplasty. So hemiarthroplasty is only replacing half of the shoulder, just the ball, not the socket. And that is not a new concept by any means. For a long time, we've used hemiarthroplasty in certain fracture situations and arthritis situations. But one of the inherent problems with a only replacing half the shoulder is now you have this metal ball rubbing against someone's own natural cartilage and bone, and that tends to erode and wear away, leading eventually to failure. We know with the standard shoulder replacement where we put a plastic socket in, that plastic socket can be the weak link. We know that over time that can become loose and become a problem for a patient. So how do we solve this problem? Well, the newest solution we have is something called pyrocarbon. And what it is that the ball of that half replacement is made out of a material called pyrocarbon, which coats that prosthesis, which is much more soft and forgiving and does not tend to wear away that bone and cartilage. And so now what we're seeing is that because we're not getting that wear, that this can be, for a lot of patients, an effective solution instead of doing a full shoulder replacement, especially in someone who is younger and that we may be concerned may wear out that plastic socket that we put in. It has gained wide acceptance in Europe and in Australia, and we're seeing more and more use of it. Here in the US, it's only been FDA approved for the past few years. And that takes us on to our last option, which is a reverse shoulder replacement. And what a reverse shoulder replacement is a type of replacement where we actually flip things around. We put a ball on the socket and a socket on the ball. And by flipping those two around, what we're able to do is create a much more stable joint that allows us to use the deltoid muscle that wraps around the top of your shoulder here to help power your shoulder. Because in these cases, we know for most patients, their rotator cuff isn't working properly. So this is something that was born out of Europe 50 plus years ago, and we've been doing it here in the United States. First became FDA approved in 2003, and since that time, in the past 23 years, have made great strides and really improved on the process of reverse shoulder replacement. And I believe it was 2019 was the first year that in the US that it flipped, that more reverse shoulder replacements were being done than standard anatomic shoulder replacements. So which one is the right procedure for patients? Obviously, that can be a lengthy discussion, but one of the things that's an absolute requirement for a standard total shoulder is a good, intact, functioning rotator cuff. And so in some patients that we see who have bad arthritis of the shoulder, it can be secondary to a chronically torn rotator cuff. So in that patient who has the unique problem of a rotator cuff tear and arthritis, here is a solution that solves both of those problems. However, both of them are great overall tools, and both of them can provide great symptomatic relief of pain and help restore function if they are done for the right reason and for the right patient. And that takes us to our next step, the Mako robotic surgery. So this is our OrthoTeam clinic here. This has been our newest advancement. We're the first in the state of Wisconsin performing the Mako robotic reverse shoulder replacement. It gives us robotic precision in planning and improved surgical accuracy for reverse shoulder replacement. So what is the Mako system? So the Mako system was a company that was bought by Stryker, which is one of the largest implant manufacturers for orthopedics in the world. And the Mako system basically allows us to use a robotic arm that we couple with the patient's anatomy to help place our components in the most anatomic position, in the position that we want them to be in. And the robotic arm that you see in this picture here is something that we use in surgery. But the important thing I really tell patients is that the robot is not doing the surgery by itself. It is not replacing me. It is a tool just like anything else I use, just like a carpenter uses a hammer as a tool. The robot is a tool that I use in surgery. And for each patient, the plan that they have that we couple with the robot is a very unique plan based on their own anatomy. So that requires a CT scan that's done ahead of time. And then that CT scan is put into software that I'm able to look at it and be able to say, this is exactly where I want to put these components, so I know I can try to get the best possible function and stability for a patient. And the robot then helps me execute that plan. In the past, we can use the CT scan to help do our planning, but it was just something that we could look at, and then we were hoping that in surgery we were able to replicate that. And it really helped with things that were very out of the ordinary, but it wouldn't necessarily help us with millimeter precision. So it starts off with getting a CT scan, like I mentioned, that creates a 3D dimensional model in our software that allows me to load that up into the Mako robotic device, and then that I used in surgery. So here's a video. I hope this one works. So let's see, is it the next page? Here we go. So this actually here, I loaded up a sample of a CT scan that I use. So I'm going to press play here. And so this is a model of a CT scan of a shoulder. So different views on these two left screens. And on the right screen, we see actually a three-dimensional model of a shoulder here. So I'm able to kind of look and scan through this CT scan right here. And you can see in this right picture now, I'm able to move this around, and allows me to really take a look at anatomy. And then I can go on to the planning part, where here, and again in 3D, I'm able to see what implants I want to use, where I want to place them. So here I'm able to change some of the settings, move things around in order to make sure I get everything lined up just the way I want it. And you can see here, as I'm doing the work here and getting things the way I want, this I'm doing on the socket side. So this is where I'm placing a ball. And here we're looking at then now at the humerus side. So we'll go to the other side, the ball side. And here again, I'm able to use this 3D planning to really dial in exactly where I want these components to be. So I do this on both sides, and then you'll see here last, I go to see the whole joint as a whole. And now the three-dimensional model can move in all directions, and it can give me feedback in terms of numbers, so I know how well the shoulder will move after I place all these implants, and it gives me data that I can really rely on. And then at the end of this, you'll see there's an option to finalize the plan in the bottom right corner here. And then what I'm able to do is take that and send that to our Mako team, and then they place that in the robot. And now the robot has the exact plan the way I want to do it. So in surgery, it's able to say and help me execute by the plan that I decided beforehand. And that type of precision is really amazing. There aren't any surprises in surgery now, and it's a really amazing technology, and I'm really glad that we're able to bring it to our patients here at the OrthoTeam Clinic. So if we do a little bit more deep dive on that robotic arm assistance, one of the things is that we talk about to help us make sure this is really accurate and does the job right, is that it has, the robotic arm has haptic boundaries. And what that means is that it won't let me push it into a direction where it's not supposed to go. So I cannot just willy-nilly push the cutting tools to do something. It will physically stop me from doing that. So it kind of creates that boundaries and won't let you go outside of them. Kind of like when you go bowling and you have the the bumpers up, you know that you can't get a gutter ball. The same way goes for the robot. It won't let me get off track that way. And it's constantly looking at the position and able to track that, and knows that for example, if I were to move the patient's arm, the robot will move with it. It's able to detect that it moves in 3 dimension and make all the adjustments accordingly. And the nice thing also too is that if I make a change in my plan that you saw in the CT scan, if I decide I'm not sure I want it this way. I'm going to move it a couple millimeters one way or the other. I can input that back into the robot, and then I can change the plan right in the middle of surgery. I don't have to do something completely different. I'm able to make those changes intraoperatively. So I can do that without leaving the operating room. So the manual technique that we used to do 20 years ago, when I started doing this at least, and people have been doing for decades, is we'd look at an x-ray and we would, obviously rely on our experience, and we would take some intraoperative measurements by hand, and then we would kind of get an idea how that would feel. And obviously now in 2026, we have the CT scan, 3D planning with that. The robotic arm gives us feedback. It has the haptic boundaries, and we know our implant placement is really well. The best way I can kind of explain this in an analogy is consider taking a road trip. So the old way we used to take road trips, at least I remember when I was a kid, is we'd have a big Rand McNally Atlas that would sit in the trunk of our car, and we would pull that out. We would kind of look at it and get a general idea, like this is how we drive somewhere, and then we throw it back in the trunk, and then we just hit the road, and hopefully we get there. Well, in 2026, for me, Mako robotic shoulder is like turn-by-turn navigation that we have in our cars now. We know that it's going to tell us how to get there each turn along the way, but it gives us feedback along the way, such as traffic, detours for construction, etc. So that way then it's allowed to adjust and recalibrate and then give us the information we need. So that way then we can make a good decision and make sure we get to our destination on time and safely. We have that type of technology just to drive around. Now we have it in something even more important, which is surgery. So the Mako difference, I think, for most patients is it's really built for everyone's own anatomy. We're not doing the surgery one way for everybody. Everyone's shoulder will be different, their CT scans will be different, and we want to make sure we plan that accordingly and execute that plan accordingly. And then also know that I can rely that what I do with the robot matches with what I see on an x-ray afterwards, and also match with how a patient does afterwards. So if we take a look at how that works in terms of the surgery process, luckily it doesn't change much for a patient in terms of their surgical day. Just like a rotator cuff repair, arriving, getting their IV, having a nerve block by anesthesia team. Surgery, same, 60 to 90 minutes with robotic guidance, back in the recovery room. Just keep an eye on things while the nerve block works, and then usually overall time of 3 to 4 hours in the hospital, patients are heading back home, with their sling. So for someone who may be considering surgery if they've failed other conservative treatment options, what do they need to know? Well, one, are they healthy enough to undergo surgery? So it's really important that anyone we consider doing surgery on, that we have good information on their overall medical care and medical conditions, and then obviously have them see the appropriate providers that take care of them to make sure that they're a safe candidate for surgery. The second part is, do you have help at home? Many patients can definitely benefit from surgery, but if they don't have the appropriate support structure, it would be very difficult for them to recover on their own. So usually that involves having somebody with assistance at home for a period of 2 to 6 weeks, and helping with things like dressing, driving, going to physical therapy, just daily tasks. So having a friend or family member for that is really important. Another important aspect is, other things that patients can do to improve their recovery. Obviously, if someone is a smoker, we know that's increased risk for a complication. So obviously we encourage patients to quit smoking or tobacco use. Patients who are diabetics, we want to make sure they have good control of their blood sugar. Physical therapy starting before surgery can also be beneficial. Other things that we're looking at that are really grabbing hold in my field are looking at nutrition. So really looking at optimizing nutrition before surgery and after surgery, so that way then you have the appropriate building blocks to heal appropriately. So the pathway looks like this. Obviously, initial consultation, make sure that everything is reviewed, and then discuss what the options are. And if a decision for surgery is made, then the next step would be a CT scan for the Mako 3D planning. In some cases, if we're not sure if someone has a torn rotator cuff, maybe an MRI would be helpful. And then the surgical planning, getting that 3D CT scan back, and then that involves me planning all the steps and make sure that I can plan and place all the components exactly where I want them. Obviously then the procedure being performed, and then usually for the vast majority of the patients, it's a same day discharge, with occasionally we'll have patients, if they have some advanced medical conditions, may stay overnight with us. This recovery for reverse shoulder replacement looks a little bit different. Sling is really only worn for 2 weeks. We let patients start doing some light activity pretty soon after surgery. So for rotator cuff repair, this is saying sling discontinued around 6 weeks, which is true. We'll talk about reverse in a second, and that is going to be discontinued at 2 weeks. But for rotator cuff repair, we know that from 6 weeks to 6 months is kind of the early recovery period, and then usually we know full recovery is somewhere from 6 to 12 months. And for shoulder replacement, we know a little bit different. We know sling is discontinued at 2 weeks and driving allowed at 2 weeks, and then physical therapy again from week 2 to 6 months, and then 6 to 12 months to full recovery. And many times it's earlier for patients. So we know that the outcomes are predictable in terms of decreasing and eliminating shoulder pain, improving range of motion. For many patients, the thing that they're happiest about is having uninterrupted sleep, and then allowing them to do all the things that they need to do on a daily basis, such as getting dressed, driving, doing tasks around the house, but then also to allow them to do the things that they love. That includes exercise and sports and activities with their family, etc. Yeah, and so, just to conclude there with that, patients regain shoulder motion, decrease their pain, and return to the activities they love. Any surgery, obviously, also has risks. We know that the risks that we always talk to patients about, these are some of them. Obviously, infection is one we're concerned about. Dislocation of the prosthesis, which is a pretty rare complication, but possible. Fracture during surgery, prosthesis becoming loose, any nerve or blood vessel injury, again rare, blood clots, stiffness, or in some cases, patients having persistent pain even after surgery. So things that influence your outcome, obviously, what we have to work with to begin with. How good is the quality of a patient's bone? How good is the quality of the remaining rotator cuff and tendon? What is the condition of the muscles around the shoulder? Someone's overall health and activity level, and then obviously the commitment to getting better. Recovering from rotator cuff surgery and shoulder replacement surgery takes time and effort, and obviously the exercises and therapy that are done are really important. So in conclusion, what I tell patients is you don't have to live with shoulder pain. There are definitely options to help regain good function and less pain. Many times that involves no surgery at all. There's a lot of non-surgical treatment options that we have, but we do know that surgery is a tool that we can use and can be used well to really help patients get back to the quality of life that they want. And that concludes my talk, so thank you everybody.